Welcome to Bone Break, the 10-minute podcast that covers basic orthopedic content for the aspiring orthopod. Get a coffee, go for a walk, or just sit back and relax. It's just bones for 10 minutes. Today's topic is orthopedic principles. I remember walking into my first operating room. It was an open reduction and internal fixation of an ankle. The surgeons and the residents were throwing around words like leg screw, cortical, cancellous, and anti-glide. Not only was I terrified of breaking the sterile field, I had no idea what they were talking about. I stood in the corner, staring at the muscles and tendons in awe as they carefully unveiled the fracture, an oblique split in the fibula. Later in the case, the surgeon handed me a screwdriver with a screw balancing on top of it and said, "Have you ever used a screwdriver?" "Not in a person," I replied, taking the driver carefully. He laughed and said, "No, to make furniture from, IKEA or something." I nodded, getting increasingly more terrified that the tiny little screw on the driver was going to fall on the floor if I held it any longer. He gestured to the hole in the plate and told me, "Go for it." After that experience, I finally understood what people meant when they said orthopedics was like carpentry. I never worked in construction or been a DIY person, so I didn't think I would enjoy learning about screws and plates. But once a resident explained the difference between a cancellous and cortical screw to me, I was hooked. Orthopedics made intuitive sense to me. Bone broken, fix it with a stable construct. While I still have no idea how carpentry or woodworking works, I do have a little bit of knowledge about how orthopedics works. We're going to start with the first orthopedic implant that I learned about, screws. A screw is just a nail with threads and a head, or, per the dictionary, a short, slender, sharp-pointed metal pin with a raised helical thread running through it and a slotted head. How do screws work? They join things together by translating rotational force, or torque, into axial compression. This conversion is achieved through the screw's threaded design, which acts as an inclined plane. As the screw is turned, its threads engage with the material, pulling the objects it's embedded to closer together, much like how twisting a corkscrew pulls a cork out of a wine bottle, but instead, in reverse. There are two main types of screws to know in orthopedics, to start with: cortical and cancellous screws. These are named for the type of bone they were made for. Cortical bone is found in the diaphysis, the shaft of the bone, while cancellous bone is the spongy bone in the metaphysis and the epiphysis. To obtain increased purchase within the softer, spongier texture of cancellous bone, the threads along the screw are spread apart and the threads are deeper. This allows for more surface area of contact between the bone and the screw. The spacing between the threads is known as the screw's pitch. With each rotation, the screw penetrates into the bone by a distance corresponding to this pitch. Cortical screws have threads closer together, since they are intended for hard, dense bone, and thus have a smaller pitch. Imagine this process similar to climbing a spiral staircase. Each step, or thread, you ascend moves you in a specific vertical distance. A steeper staircase would correspond with a screw with a larger pitch, allowing for more rapid vertical movement, or in the case of the screw, deeper penetration into the bone with each turn. This difference in pitch optimizes each screw type for its specific application, much like how different staircases are designed for different needs, be it quick ascent or easier climbing. Both cortical and cancellous screws can be fully threaded or partially threaded. This means that the threads may wrap around the entire length of the screw or only part of the way. This is especially relevant for the next section. Leg screws. Eventually, after spending more time in ortho ORs, I heard the word leg screw thrown around, so eventually I worked up the courage to ask, what does legging the fracture mean? So, as the junior finished suturing, the senior drew me a diagram on their surgical drapes. This concept can be tricky without visual aids, so if you're still confused at the end of the podcast, see our show notes for more details. A leg screw in woodworking is used to compress two pieces of wood together. In orthopedics, it's often a way you can compress two bone fragments of a fracture together, known as interfragmentary compression. One screw can put two pieces of wood together. By putting the pieces together, eventually, the wood, or in this case, the bone, will heal. Leg screws can be used independently or through a hole in a plate. In both situations, compression occurs, either between two bone fragments or between the plate and the bone, generating friction. There are two ways to leg two pieces of bone together, either by technique or by design. In both cases, the key is that the screw must be placed perpendicular to the fracture site, or else tensioning the screw will cause the fracture edges to displace. By design. A partially threaded screw is passed perpendicular to the fracture line. The threads will pull the distal fragment towards the proximal fragment, which is engaged by the screw head, ultimately creating compression across the fracture. It is important to make sure that none of the threads of the screw are embedded in the proximal fragment, as this will not allow for proper interfragmentary compression. By technique, a fully threaded screw is inserted. However, the proximal cortex is over-drilled, that is, drilled to a larger diameter than the screw's outer diameter, so that the distal threads are what engages in the bone and, when tightened, compress the fracture. Again, the proximal cortex does not engage with the screw heads. This is an important concept to understand if you want to begin to understand surgical planning in orthopedics. Bone healing. Before we go any farther, in order to truly understand orthopedics, one must understand how bones heal. As one of my attendings told me, bones have been healing just fine by themselves for years. Orthopedic surgeons were invented to make sure that they heal in the right position. Consider a scenario where a fractured bone is left to heal naturally, without directly aligning or compressing the fragments together. In this case, such as when we use close, reduction, and casting, secondary bone healing occurs. This process, which occurs in the absence of rigid fixation, progresses in 4 stages: hematoma formation, granulation tissue formation, bony callus formation, and finally, bone remodeling. In contrast, primary healing occurs when the fractured bone is stable and rigid, with the fragments tightly compressed together so that the haversian canals are in such close proximity that they begin remodeling immediately without callus formation. This will be relevant when we talk about plate types. Plates. Now, a screw can hold a piece of wood together just fine, or in this case, a bone together. However, the bone may encounter other forms of tension and stress in other directions that the screw can't overcome by itself. That's what plates are for, to resist stress or to provide additional stability for the fracture. Plates can provide absolute rigidity when we want to induce primary bone healing. There are 4 types of plating that we will cover today: neutralization, compression, bridging, and buttress/anti-glide. Neutralization. This type of plate does exactly what the name suggests. It neutralizes forces along the fracture. For example, in the ankle, once a leg screw is placed, a neutralization plate can be added to the construct to help resist further rotational stress on the bone, which may redisplace the fracture site before it has the chance to heal. For example, in the ankle fracture, once a leg screw is placed, a neutralization plate can be added to the construct to help resist further rotational stress on the bone. Compression. These plates are also named for their function. There are multiple ways they can be used or placed, but hypothetically, a single compression plate could be used to fix a simple fracture. The plate has holes designed to allow the plate to move along the bone to provide compression. Again, this helps facilitate primary bone healing that minimizes callus formation and the amount of remodeling that needs to take place. Buttress or anti-glide. Named for the architectural technique, like the buttress of a citadel, these plates resist vertical and axial forces, best demonstrated by a tibia plateau fracture. If you think about the flying buttress that holds up the ceiling of a church, that design is used in these plates to hold up pieces of bone that want to translate vertically, such as the lateral plateau of the tibia. You will learn more about this in episode 5. Bridging. This plate works by keeping fragments of comminuted fractures in place and allowing healing by callus formation through indirect or secondary bone healing. There's an article in our show notes with diagrams that explains this in depth. As a medical student, you aren't expected to understand these concepts in too much detail, but some familiarity makes the operating room a little more exciting and interesting to be in. In one of my electives, my resident challenged me to learn about the different types of plating used in orthopedics. To be honest, I struggled with understanding these concepts as my internet search didn't provide many medical student-friendly content. My hope is that this episode provides a brief, beginner-friendly approach to orthopedic implants such as screws and plates. We hope after this podcast you can describe the difference between cortical and cancellous screws. Describe the difference between lagging by design versus by technique. You can describe 4 different types of plating in orthopedics. So, next time if you find yourself in an orthopedic OR, hopefully this episode has given you the foundation to begin learning about the techniques we use to put bones together. I promise you do not need any knowledge of construction to learn orthopedics. Now, I am logging off to go struggle with IKEA furniture, since I still need to finish building that. Thank you for listening to Bone Break. I'm your host, Dr. Cade Van Kampen, and we'll see you next time as we explore one of the most common orthopedic problems, distal radius fractures.